Good morning, everyone. I'm pleased to welcome you to the 7th Annual Georgian Bay Healthcare, Wellness, Research and Innovation Day. My name is Dr. Mike Alisi, and I'm the Chief of Staff here at the Collingwood General Marine Hospital. And I'm going to be the facilitator for today's event, which is a collaboration between the Collingwood General Marine Hospital, the Rural Ontario Medical Program, Georgian College, the Town of Collingwood, the Town of Blue Mountains, the Township of Clearview, and the Town of Wasaga Beach. Our theme this year is Green Healthcare. Our aim today is to give you the opportunity to learn and explore some of the great research and initiatives taking place locally in the southern Georgian Bay, as well as in the province, the country, and the world. Upon receiving positive feedback from our 2021 adapted virtual event, we are returning this year with a live streaming platform so that we may continue to share knowledge and innovation from across this province and the country. For those of you who attended this event in the past, you'll recall we had a large display of research posters and quality improvement projects lining the halls of the hospital when this was in person. Similar to our last research day, these posters are available online at the CGMH and Rural Ontario Medical Program online events websites. There's a link that's available online. It's our hope that you will browse through these posters, which highlight the outstanding initiatives being done around our area, and reach out virtually to have conversations about local innovative research. We are very excited that you are all able to join us, and I want to thank those who have tuned into the live stream to participate in today's event, and of course our 7 speakers who are lending their time and expertise. If you have any specific questions for the speakers, please use the chat box below the live stream on the YouTube. As I mentioned, our focus for Research Day this year is green healthcare. And with the increase in awareness for sustainable and environmentally conscious initiatives, it's important to explore how healthcare can move in this direction. I hope that this event can answer some of your questions as well as prompt you all to think about healthcare moving forward as we attempt to evolve our current methods into sustainable ones. Before we get started with our speakers, I want to thank a few individuals who helped today to make that happen. From our partners, Jennifer Parker from the Town of Collingwood, Alan Gibbons from the Town of Blue Mountains, Caitlin Monsma from Town of Wasaga Beach, Dr. Peter Wells and Michelle Hunter from the Rural Ontario Medical Program, Brenda Berman and Sarah Lancashire from Georgian College, and our team here at CGMH, I want to thank you all. Now back to the lineup. We have a fantastic lineup of speakers that are presenting today and some great opportunities to network virtually with stakeholders from a variety of professional backgrounds. As this is an interprofessional event, be sure to ask questions, connect with us, learn from professionals that you may not have otherwise have had the chance to interact with in your scope of practice. If you're a community member, just chime in and ask a question. We're truly stronger when we're all doing this together. So welcome, and please enjoy our presentations. Our first speaker is Dr. Nicole Sims, and please join me in welcoming her. Dr. Nicole Sims is the Training and Education Lead and Executive Lead of Cascades. As Training and Education Lead, Nicole Sims guides the design, implementation, and evaluation of Cascades' continuing professional development portfolio via websites, webinars, workshops, coaching sessions, and a variety of educational offerings developed in collaboration with health partners. Nicole seeks to deliver interdisciplinary learning opportunities that build pan-Canadian capacity to provide low-carbon, high-quality care. Prior to becoming a member of the Cascades executive, Nicole played a foundational role in the emergence of Cascades' lead organization, the Centre for Sustainable Health Systems at the University of Toronto, where she served as managing director. Nicole holds a PhD from the Department of Geography, Environment, and Society at the University of Minnesota, and an MA in Geography and Environmental Studies from the University of Toronto. She has taught various courses related to environmental sustainability at the University of Toronto, the University of Minnesota, and Macalester College. Welcome, Dr. Nicole Sims. We look forward to your presentation on Cascades, creating a sustainable Canadian health system in climate crisis.
Hi, everyone. My name is Nicole Sims. I'm here from Cascade, which stands for Creating a Sustainable Canadian Health System in a Climate Crisis. And I will tell you more about our organization in a moment. First, I just want to thank you so much for having me here today. I'm really excited to speak with all of you about the importance of sustainable healthcare. I do want to acknowledge the lands from which I am joining the gathering. So I am at the University of Toronto, which for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and is still today the home of many Indigenous peoples from across Turtle Island. So very grateful to be able to work on this land. So in my brief time with you today, I want to quickly make the case for sustainable health systems, show you a framework for low carbon, high quality care, and then tell you a bit more about our organization and how I hope we can support you as we all work together to address health system sustainability. So first, making the case for sustainable health systems. Hopefully I don't need to convince anyone that climate change is happening. We certainly have preponderance of evidence showing that under simulated conditions, just looking at kind of the natural progression of things, we have a very stable climate, of course, with a bit of natural variation. But the observed climate that takes into account human and natural activity shows a dramatic increase over the past 40 or 50 years. And the scale at which the climate is increasing in temperature, it doesn't seem huge, but it is big enough to have significant impacts on both the environment and human health. So this is a chart that's been put together by the Centers for Disease Control, and you can see here all of the different impacts that climate change is having on the natural environment, and then the associated impacts on human health. So just to give you an example, on extreme heat, for example, we've got heat-related illness and death, cardiovascular failure. When it comes to severe weather events, we see injuries, fatalities. We also see mental health impacts associated with that kind of uncertainty and the difficulty of confronting those events. So a lot of different health effects related to the changing climate. And some of you may have heard about this, but this is why in 2021, a BC doctor was the first person to diagnose one of his patients with climate change because he felt that all of the symptoms with which she was presenting were sort of synonymous with the effects that climate change would have on human health. But it's not just the effects of climate change on human health that we're concerned about. So there are kind of these direct impacts on human health, but there are also ways in which climate change impacts our systems, including the health system, that compromise our ability to provide health services. So this is a great graphic that just shows all of the different ways in which climate change affects health systems, the social and structural determinants of health, and the ecological determinants of health. So there are so many direct and indirect impacts that climate change has on health that it's something that we really, really need to start taking seriously as health professionals. And just to highlight the impacts that climate change can have on healthcare infrastructure, this image shows all of the different sort of disruptions that have been happening in recent years to our ability to provide health services as a result of changes to the climate. So I'll just give you a moment to maybe pick one or two and take a look at them. But, you know, when we used to think about the impacts of climate change, you know, on the environment or on health, it seemed like something that would be quite far off, but that's no longer the case. Certainly, climate change, it's not just in our backyard, it's in our front yard, right? So it's really, really important that we understand how climate change is impacting, you know, not just health, but our ability to provide health services. So this is why response number one to the threat of climate change is adaptation and resilience, right? So acute shocks in the climate, they increase demand for health services, but at the same time, they reduce our capacity to respond to that demand. Also going on is these chronic stresses develop that increase needs, but also challenge our ability to provide operations. And so there have been many attempts to address health sector resilience, a lot of different plans out there. I'm showing you this schematic from the WHO, and you can see that, there are attempts to figure out how can we make the health system better able to withstand the shocks of climate change or able to adapt when something does happen so that we can continue to provide health services. But there's a flip side to this, right? So yes, climate impacts health and health systems, but health systems also impact climate. So it is said that if the health sector were a country, it would be the 5th highest emitting country globally. And about 5% of global emissions are related to the health sector, which is on par with the aviation industry. So this will probably, I may be preaching to the choir. Some of you are very well versed in this and you're already making great strides when it comes to addressing health sector sustainability. Others, maybe you're not quite there yet, but you may have seen some things happening around you that have really maybe given you pause, and maybe this isn't all that surprising to you. This is an image from Dutch spatial artist Maria Koik. She collected all of the materials that were used for her surgery, including her anesthesia, and she laid out this image, which is quite striking, that this is all from a single surgical procedure, right? So we can imagine all of the ORs across our country, all of the surgeries that happen every day, producing just this mountain of waste. And so just to give you a sense of kind of where Canada falls here, about 4.6% of our national emissions are related to the health sector. And you might think, oh, because we have, of course, health facilities are large, they're going to have associated emissions that are large. But actually, about 60% of health sector emissions are embedded in care delivery, and that includes products and services. So I don't know if you've been able to identify Canada here yet, but here it is. So this is showing you our per capita health sector greenhouse gas emissions relative to our healthy life expectancy at birth. So you can see Canada basically has the 2nd highest per capita health sector emissions across the world. And it's not actually as if all of those emissions are putting us at a higher life expectancy relative to other countries, right? So you can look at a country like France, which has a even slightly higher life expectancy, but is falling much lower on the per capita carbon emissions scale. So none of this is to say we don't need to deliver health services. We, of course, want to provide necessary health services, but we want to ensure that they are as least environmentally impactful as possible while still, ensuring that human health is maintained. So this is why, in addition to that response number 1, resilience and adaptation, there's a second response that we need to make, and that is mitigation. And so I have a quote here from a paper about the sort of environmental benefits that might be associated with virtual care, but the author notes this paradox that if the sector does not introduce climate-friendly policies and practices, it paradoxically will continue to contribute directly and indirectly to negative health impacts. So how can we disrupt that process? How can we stop what's happening where the very sector that is tasked with protecting human health is actually contributing to a problem that, worsens human health, that puts it at risk? So I want to show you very quickly a framework for low carbon, high quality care. And this is a framework that's being developed by Dr. McNeil and a few others. And there's basically 3 components to it. And so the first one is to reduce demand for health services. So we want to improve health so that we reduce the demand for care, which does have a carbon footprint, right? So we want to see the incidence and severity of disease decrease, and therefore we have the amount of care and the intensity of care decreasing alongside that. And we know that only about 20% of our health is determined by medical care. There are so many other factors that contribute to our well-being. And this is why we're starting to see the integration of health into all kinds of policies, not just health-related policies, but policies related to energy, housing, industry, transportation, etc. There are so many opportunities for health promotion and disease prevention or better management of diseases so that they don't progress to going back to this idea of, where carbon emissions are generated within the health sector. This is a pie chart from the National Health Service in England that shows that the bulk of emissions are actually being generated relative to our supply chain. So, lots of opportunities across the system to address carbon footprint, but there's a really great amount of opportunity in that area. And this work is really in alignment with a lot of the work that's already going on to improve health services. So, we don't need to just address sustainability out of the goodness of our hearts. There are health co-benefits associated with improving these elements of our care delivery. We're already working on appropriateness through Choosing Wisely Canada. We are working on quality improvement initiatives and person-centered and integrated care, and sustainability just slots very nicely into all of these initiatives. It just hasn't been sort of formally recognized there in the past. If you do go to Choosing Wisely's website now, though, they do, up front and center acknowledge the importance of appropriateness to addressing the health sector's carbon footprint. So sustainability is really already part of our job. And so even though there are a slew of opportunities to really tackle sustainability head on, and I'll briefly talk about those in just a moment, I want to encourage you to look at what you're already doing and consider whether or not there might be a sustainability component. So, look at your work with a green lens. This is an example of a campaign to prevent surgical site infections on behalf of the Ontario Surgical Quality Improvement Network, which is right now running a great Cut the Carbon campaign. But this was a past campaign, and they had some great success reducing SSIs. Well, it turns out that SSIs have a carbon footprint. So that work had a sustainability component that they hadn't even considered. So just food for thought, even if anything, it seems kind of out of range right now to actually tackle sustainability head on, think about what you're already doing, and that might kind of galvanize you to move forward on some of these bigger initiatives. So just really briefly, I'm going to tell you a bit about Cascades because, again, we're here to support this work across the health sector. So we are a project. We're funded by Environment and Climate Change Canada through a community engagement and awareness grant. So we have a 5-year mandate that we're about halfway into. We're based at the University of Toronto at the Centre for Sustainable Health Systems. But we have several partners, including the Healthy Populations Institute at DAL, the Planetary Healthcare Lab at UBC, and the Canadian Coalition for Green Healthcare. So we consist of these 4 partner organizations. So we do training and education to really strengthen the capacity for change. So I encourage you to, take some of our courses, come to our events. We develop resources to fill the implementation gap, and I'm going to show you a few of these in a moment. And we also do collaboration building to really foster pan-Canadian coordination on low-carbon sustainable care. So there's so much amazing work going on. We work to kind of harness that work, bring everyone together so that we can learn from what's happening and move forward on the lessons that we can all bring to the table on this. So just want to, before I close, just really quickly highlight some of the resources that we have available, which I hope you will check out and use. So we kind of have these 2 domains of activity. Our first domain is sustainable care pathways. So we develop resources in specific areas. So for example, we have some what we call playbooks that are kind of like how-to guides to initiate sustainable projects on climate conscious inhaler prescribing. We have one up on outpatient care. We just posted one on inpatient care. We have a couple on sustainable perioperative care, sustainable pharmacy, on virtual care. And then our second domain is kind of at the system level. And so we have some playbooks on organizational readiness, how to integrate QI into how to integrate sustainability into QI. So it's actually a training manual. So if you run any QI courses or just do QI projects and want to think about how you can actually add a sustainability element, please check that out. And we also have a playbook on greenhouse gas estimation. Canada did make a commitment at COP26 a couple of years ago, almost now, to address health sector emissions. Not exactly clear, no solid guidance on exactly how we will get there, but this playbook is a start to understanding how institutions across the country are trying to measure their greenhouse gas emissions. And I just want to leave you with, this. There are tons of institutions who are already doing this. I'm sure some of you, lots of people doing work at the project scale, which is supremely important, but at the institutional level, North York General Hospital integrated sustainability into its quality improvement plan for 2021. Hamilton Health Sciences has set a target of reducing greenhouse gas emissions by 50% within 3 years. Tons of organizations have been eliminating desflurane from their formulary and replacing desflurane with sevoflurane for anesthetic gases, which is much less carbon intensive. Peach Health has been keeping track of the organizations that have been doing this. And actually, I just got word that a pharmacist from Lumeo Healthcare, which consists of Kingston, Brickville, Addington, Perth, Quinte, and Providence, just got all hospitals to remove desflurane from their formulary because they're implementing Cerner, and they realized that all the hospitals' formularies need to be coordinated. So they just said, okay, let's get them off here. And I think that's also a great example of how interdisciplinary this work can and should be, with lots of different people across the health sector able to play really important roles. And then also professional societies. I know Dr. Orling will discuss Ontario's anesthesiologists' recent position statement on applying circular economy principles. Canada's Anesthesiology Society recently included guidelines on environmental sustainability in their recent practice guidelines. So there's just an explosion of work happening on this. And I really encourage you to check out, what your department is doing, what your institution is doing, what your professional society is doing, what your province is doing. And just, if you're not already on board, get on board and let us help you get there. So thank you so much. Please be in touch.
Great. Thank you, Nicole. That was fantastic. Thank you so much. Maybe we'll just take one question if that's okay. I know that as you stated in your presentation that when care is truly needed, ensure that it's appropriate, which can help avoid some of those pollution components and carbon footprint components. With this in mind, how can healthcare providers avoid the overuse of products that can harm the environment while balancing the needs of the patient?
I think that there's actually a great amount of literature coming out on sustainable healthcare. Some of it is more general, but a lot of it is actually very specialty specific. And in particular, we see a lot coming out in anesthesia, infectious disease, dentistry, and a few other areas, but a lot of different areas are starting to see a lot of publications on this. So we actually support a database called Healthcare LCA, which stands for Life Cycle Assessment. And a life cycle assessment is when you sort of look at all of the inputs and outputs that go into either a product or a process or a service and try to understand its environmental impact. And so I would encourage people to, if you really want to look into a specific surgery even, go on to Healthcare LCA, see what's being written out there. There's new work coming out all the time. Obviously be attentive to the context in which it is produced. We don't need to get into the nitty gritty of this, but some work that's done to try to estimate the carbon impacts of using, a reusable version of something versus a disposable version. If it's done in Australia, it might actually show the reusable having a higher carbon impact, but that's because Australia's grid is so coal heavy, whereas our grid is much cleaner. And so the balance shifts to the reusable being much better environmentally. So there's tons of opportunities. There's tons of information out there and more growing daily. And so I think that's a great place to start. But also just looking at the guidelines from Choosing Wisely Canada on appropriateness of care for your specialty. Because again, even though those guidelines didn't originate with a specific sustainability mandate, they have huge implications for sustainability. So those are just a couple of ways to kind of get started in thinking about that.
Yeah, that's great. Thank you so much, Nicole. I know we have first speaker and a few little glitches in the beginning, but I think the virtual world does allow us to have you come and present here. Again, once again, thank you so much for your expertise, and we appreciate you joining us here today.
Yeah, thank you so much for having me, and I look forward to the rest of the session. So
great. Thank you. There'll probably be some other questions in the chat box and whatnot. Feel free to address as you see fit and whatnot.
I will stick around.
Appreciate that.
Yeah. Thank you.
Awesome. Okay, so we'll move on to our next speaker, and we are very fortunate to have one of our own physicians from Collingwood General Marine Hospital come and give us a talk today. So our second speaker is Dr. David Orling. He's an emergency physician and the chief of the Department of Anesthesia here at the Collingwood General and Marine Hospital. He graduated in 1990 from the Schulich School of Medicine and Dentistry at Western University, and from there he finished his family medicine residency in 1992, then accomplished completing a fellowship in emergency medicine in 1996, and another in anesthesia in 2000. Currently, Dr. Orling is the physician lead for the Ontario's Anesthesiologists Environmental Sustainability Working Group, and this group formed in 2022 to bring together a small group of Ontario anesthesiologists who wanted to collaboratively work together to make our healthcare system greener. They're working towards creating a circular economy to create sustainable communities, a mission of which Dr. Orling is now taking action on. We are honored to have Dr. Orling as our second speaker in a presentation on No Time to Waste, a circular approach to greening the operating room.
Thanks very much, Mike, for this opportunity and for your vision in choosing green healthcare as a theme this year. Hopefully this will go smoothly, and I have my screen up to be shared. This morning I'll be speaking about applying circular principles to green our operating rooms and why we have no time to waste in addressing the issue of healthcare sustainability. I appreciate very much Nicole's talk and the work that Cascade's been doing, and I'll try and build on some of that, including touching on some of the topics and some of the resources that she's already talked about. What I'd like to do in the next 15 minutes is contrast linear and circular resource use and discuss how a circular approach can improve how we operate. The examples I use are from the OR, however, the principles are applicable to any healthcare setting as well as our daily lives. I'd like to leave you with an appreciation of the scope of the issue and some ideas to help turn things around. I'd also like to get your input, so please, if you could take out your phones or open another browser window on your computer, we'll cross our fingers that this works. But I have a few disclosures to make, and while I do that, I'll ask you to make one as well. I'd just like to know a little bit more about who you are. So if you could scan the QR code on the bottom left of the screen or follow the instructions on the top, let us know who you are, and then think about why greening healthcare is important to you, and I'm going to tell you why it's important to me. As a physician, a father, and someone who enjoys being active outdoors on days when it's not full of smog or smoke in the air, I feel we're grossly underestimating the future impacts of climate change, biodiversity loss, and environmental pollutants. My work in the operating room has allowed me to witness many remarkable innovations in surgical care, as well as the increasing amount of waste that we produce in our ORs. Planetary health and our own health are directly connected, and I'm often struck by the disconnect in how we and the larger systems that we are part of treat this issue. There are choices and actions that are needed today to protect the future health and well-being of all members of society, both locally and globally. I feel that healthcare professionals have an obligation to find solutions, and adopting a circular approach to resource use is one of those solutions. It requires a holistic view and a willingness to connect the dots, and I hope we can achieve that today. I don't have any financial conflicts to declare other than the fact that I have not paid for a parking pass for 20 years, and I'm grateful that CGMH continues to provide free preferred parking for bicycles. This work is my contribution in return. The discussion about parking is often much talked about one at CGMH, so I just thought I would highlight that for our audience today. Our current state is predominantly based on a linear economy. We take resources, we make something, and we use it for a limited time, and then we waste any remaining value by throwing it out. There is a cost in terms of resources and energy in the production of the product. In most cases, currently, those energy costs come from burning fossil fuels, which is the driver of climate change. When the product is discarded, those resources are lost to future use. In the hospital or as taxpayers, we pay to have our waste hauled away. We also pay indirectly by ignoring the environmental and social costs that this model has. Then the process is repeated. Our linear economy thrives on short-term financials while hiding the externalized costs which we must account for. This is some of the equipment used in our operating room for a simple orthopedic procedure. That's to remove the hardware from a patient's arm after a fracture is healed. Except for the laryngoscope handle, some of the surgical instruments, and the silver sterilization box, everything else is designed for single use and is disposed of at the end of the procedure. Healthcare's impact on greenhouse gas production, the driver of climate change, is approximately 5% in Canada, as Nicole alluded to. Environmental pollution is increased in the take, make, waste economy. I'll give some specific examples of that later. People have looked at this. More than half of healthcare's climate change impact comes from the supply chain, the stuff we use. CGMH, even though it's a smaller hospital, generates 23 tons of waste on average each month, the majority of which is trucked to landfill between London and Sarnia. Operating rooms have been shown to generate between 20 and 33% of hospital waste. We need to reduce those numbers. During my career, I've witnessed the shift from reusable to single-use devices and supplies, almost all of which are synthetic plastics derived from fossil fuels. We are in the midst of a climate crisis, which adversely affects our health, and the paradox is that our healthcare system is contributing significantly to the problem and undermining its stated purpose. The circular economy, by contrast, aims to create and maintain value, with value being redefined to focus on quality while also taking into consideration social, environmental, and financial costs. You may have heard of this referred to as the triple bottom line: people, planet, and prosperity. Products are designed to remain in use and retain their value. In many respects, the circular economy aims to emulate natural systems, which are resilient, regenerating, and grow sustainably. This diagram is from Switzerland's Department of the Environment. A circular approach can be viewed as multiple intersecting circles, with the principle being the retention of materials and value by various pathways. The green arrows on the left are resource inputs, the gray arrows on the left are resource inputs and waste outputs. The objective is that these are minimized and ideally eliminated, with natural systems, which are the smaller green circle on the left, able to absorb, recycle, and regenerate as needed to keep the loops closed. A circular economy also includes a full accounting of the externalities, the unintended or ignored consequences, the upstream and downstream effects of a process. I'll ask for your input again, and this should come up on your screens automatically, or if not, you can scan the QR code again on the left or follow the instructions up on the top of the screen. And I just asked you to think about what operating room devices or supplies you could think of could be used in a more circular way. If you don't work in an operating room, you can envision yourself working in the operating room of the future. Or if you'd rather just contribute an example from your own workspace, that's great too. I'll give everyone a minute and see what we come up with. Yeah, surgical gowns is certainly a big one. We may be having some issues with this, or if you're having some troubles with that part of your screen, that's fine. We thought we'd give this a try. We're trying to be innovative. And extra supplies from kits, definitely. So clearly there's some great ideas out there and plenty to fix. I'd like to discuss some projects that people are working on now and where I think we need to go. And we'll build on the reduce, reuse, recycle framework that everyone's familiar with to do that. Reducing unnecessary use of supplies is the obvious place to start. The Ontario Surgical Quality Improvement Network, which CGMH has been a part of since inception, has helped us reduce our surgical site infection rates and perioperative use of narcotics. These programs have been very effective. This spring, OnSquin, to its credit, launched the Cut the Carbon Reducing Surgical Waste campaign, with hospitals across the province participating. The Bring Your Own Bag Change idea asks patients to bring a bag to put their clothes in when they come to their procedures. A simple idea. Until recently, everyone was given a plastic bag which was thrown out after use. Changing the instructions given to patients has been well received and will reduce thousands of plastic clothing bags from being produced, purchased, shipped, stored, stocked, used once, and then collected, trucked, and dumped unnecessarily or incinerated. All the steps in this process are eliminated, and the financial and environmental costs saved. The Gloves Are Off campaign in the UK educated staff on the appropriate use of disposable gloves, improved hand hygiene rates, cut glove use by 20%, and saved thousands of dollars for participating hospitals. Choosing Wisely initiatives have been implemented and very effective as well. Reducing unnecessary testing for preoperative patients and knee arthroscopies for indications not shown to be of clinical benefit are two examples that have saved resources, energy, time, money, and reduced healthcare's environmental impact. Our medical device reprocessing department has been a tremendous resource in promoting and ensuring we can use and reuse our surgical equipment in a circular fashion. CGMH has recently been replacing its sterilization trays with ones that don't require blue polypropylene wrap. Both of those are shown in the picture that's at the top. The instruments can be reprocessed with less waste and without the risk of perforations in the wrap, which can result in a case being canceled due to sterility concerns, which we obviously all want to avoid. CGMH has reprocessed reusable anesthesia face masks, laryngeal mask airways, and spinal trays, and refused to allow suppliers to substitute single-use products on more than one occasion in the past few years. One of the important benefits of reusable equipment is reliability, availability, and the avoidance of supply chain interruptions, which have become a frequent occurrence recently. A low-carbon, sustainable, and resilient healthcare system is our goal. Repairing equipment when needed is an integral part of a circular approach. More expensive equipment such as drills, endoscopes, and laparoscopes, and those are the equipment that's used to look inside your colon and inside your belly when doing operations. Those are usually purchased with service contracts, some of which include manufacturers taking back the equipment at the end of the term. This is called service as a product, and it incentivizes the design and maintenance of value in equipment as opposed to high volume, low cost sales, which have disposable as part of the model. CGMH has a biomedical engineer on staff whose responsibility it is to maintain equipment in good operating condition and arrange servicing when needed. Repurposing and recycling are other options for equipment when they're no longer suitable for their original intended purposes. High quality materials such as paper and metals, to some extent glass, and in limited cases plastics are recycled. The standard that recyclable material should be measured against is the ability to make the same product from the same material, again, with little or no toxic byproduct. The reality is that less than 9% of plastics that enter recycling streams are recycled. A model that relies on recycling single-use plastic products might make us feel better, but won't address the impacts of production and eventual disposal. Recycling has a role to play, but we cannot recycle our way out of the healthcare waste issue. How do we move forward? Rethinking our approach to care is necessary. Anesthetic gases have been the mainstay since ether was first used on patients almost 200 years ago. The recognition that anesthetic gases are potent greenhouse gases has led to a rethink of anesthesia care. CGMH removed the anesthetic gas desflurane from use last year due to its excessive footprint with no significant clinical impact compared to other options. This is one of those choices that hospitals need to start making. A growing list of hospitals in Ontario are now doing the same. Other techniques, including the use of local anesthetics for nerve blocks and wound infiltration, have reduced our use of anesthetic gases significantly. There is more we can do, and the plan needs to include continuous innovation and improvement. Removal of our hospital's central nitrous oxide supply, another potent GHG, also took place last year after studies were shared that most of these gases leaked and were wasted before ever reaching the patient. Ultimately, gas capture and reuse are needed if we are to use them in a fully circular fashion. And there are companies working with that objective in mind. Another rethink is using tap water for endoscopy procedures, including instead of sterile water that comes to us in plastic containers. Given that our GI tract is far from sterile, if we can drink the water, why can't we wash your stomach and colon with it? This innovative but simple idea, which is being studied, may close another loop and reduce more waste. The most significant rethink, though, needs to be in our view of resource use and looking at the bigger picture. We must move beyond short-term thinking in our decision-making. Research is an essential component of quality improvement. Waste audits can be helpful to identify which items to target and to monitor progress. Pictured here are 3 commonly used items that are deemed single-use by the manufacturer. Ontario's Anesthesiologists, ESWG, our Environmental Sustainability Working Group, is partnering with some chemical and materials engineers at the University of Waterloo to investigate how these items might stand up to appropriate cleaning for reuse. Studies have previously shown that extended reuse of LMAs, of reusable LMAs, could safely extend their lifespan by at least 2.5 times. Life cycle assessments are studies which look at a product from cradle to grave inclusively. Single-use products are touted as reducing risk from an infection control point of view without studies actually demonstrating benefit. What is demonstrated when life cycle assessments are done is that the environmental costs of reusables are significantly lower, especially when clean electricity is used in reprocessing, and that financial costs are lower as well. Environmental impacts on average are reduced by 50% with reusable LMAs, and per-use financial costs by 20%. Extended reuse would amplify these savings further. Reusable surgical gowns have also been shown to have less environmental impact and financial costs per use than disposables, with a recent review by the Ottawa Hospital making the case for switching back to reusables. Switching to reusable gowns is one of the change ideas in the on-screen Cut the Carbon project. Ultimately, we need medical devices and supplies to be redesigned for circularity. Specialty instrument trays that are sterilizer ready and don't need blue polypropylene wrap, suction equipment that minimizes the disposable component and uses non-fossil fuel derived biodegradables, anesthesia airway equipment that can be reprocessed. And we need reform in our healthcare culture so that procurement policies and legislation shift manufacturers to providing products and services that ensure people, planet, and prosperity are all factored in. While we have work to do at CGMH, our senior leadership team deserves credit for taking some essential steps. CGMH has included environmental sustainability in its strategic goals and empowered an ESWG that includes administrative, building, and environmental services, clinical and food services representatives. We also now have a sustainability policy in place that recognizes the link between a healthy environment and a healthy population and outlines the necessary steps needed to ensure we remain a leader in protecting the health of our community. More hospitals are making these steps, as Nicole mentioned, at Sunnybrook and Hamilton Health Sciences, and we need others to follow suit. How do we grow the circle? Through partnerships, commitment, alignment, and advocacy, we can reform how our system uses resources. The Canadian Medical Association has published an unequivocal call for change, including the reduction of single-use products, the decarbonization of supply chains, and sustainable procurement. Cascade is working to create a sustainable health system in a climate crisis. I'd encourage everyone to view their resources, including the Sustainable Perioperative Care Playbook, especially if you have involvement with an operator. The Cut the Carbon project through Health Quality Ontario is giving hospitals practical ideas and experience and raising the profile of this issue within our provincial healthcare system. Ontario's anesthesiologists recently published a position statement on applying circular economy principles in operating rooms and is also working to eliminate the use of desflurane from hospitals throughout Ontario. The Canadian Coalition for Green Healthcare and PEACH, you'll hear more about those later, are bringing together manufacturers, group purchasing organizations, hospital procurement managers, and clinicians to discuss how to incorporate environmental considerations in supply chains and use collective purchasing power to reform procurement. We need redesign in the system, and these roundtables will help facilitate that. Overall, we need healthcare leadership to embed sustainability in the culture at their facilities. We need the Ontario Hospitals Association and Ontario Health to play a necessary role. We need to make circular approach to the way our health system operates. So I'll open up the last question now, and I'll just ask you, when you think about sustainable hospital resource use, to let us know, share what words come to mind. I'll give you a hint, they all start with the letter R. And I'll just take this opportunity to thank the staff at ROMP and CGMH for organizing what I'm sure will be looked upon as an extremely impactful event. I hope this presentation has given you a better understanding of what a circular approach to resource use is, some examples from the operating room as to what that approach looks like, and reasons why we need to change. Planetary health and human health are interconnected, and there is an environmental imperative to reform our system. We're in the midst of a climate crisis, and our use of our ecosystem's resources outstripping its ability. And we need to rebalance things and have healthcare be part of the solution. And that's fantastic. Thanks very much. I'll turn it back to you, Mike, and if there's any questions, I'd be happy to answer them.
The first question is, you have mentioned reusing and reprocessing surgical equipment as an important part of circular OR approaches. And this individual has heard that you have done some work with reusing laryngeal mask airways. Would you be able to expand on the outcomes of this project in particular?
Yeah, sure. Thanks. That's a great question. We've actually been using reusable LMAs for years. And so we've had a system embedded in place that's been that's worked very well for us. And we've been very fortunate to be able to do that. And that has our MDRD department plays a big role in that. We actually faced a situation a few years ago where the supplier indicated to us they wouldn't be able to provide us with reusable LMAs anymore. And at that point, we were able to say no. We found another supplier and we got the product that we needed. We've outlined the process that we used with Cascades and their Sustainable Perioperative Care Playbook. And the Perioperative Care Playbook has our process in there. And if anybody would like to look at it, as mentioned, that's a great resource to look at and to use. But you know, the important part of it is developing a system that makes sure that everybody plays their part in the circular nature of the reuse. And as mentioned, you'll save resources, you'll save money, you'll save the environment. I think it's a win-win all around.
That's great. Thank you so much. Thanks so much.
Thanks so much again, Dave, for coming and speaking to us and sharing your expertise and experiences. Greatly appreciated and valued.
Yeah, my pleasure. And thanks again for organizing this.
Take care.
Take care.
Okay, so we're going to move on to our next speaker. I know that our timing and our scheduling is off a little bit, but I hope you'll appreciate the value of all the great work that's happening. And so our next speakers are Rebecca McDonald and Robin Snell, who are both from Parkin Architects. Rebecca McDonald is a senior associate and senior clinical planner at Parkin Architects with over 11 years experience in a wide range of healthcare projects. She's the lead of Parkin's Design Excellence Group and an advocate for both evidence-based design and Parkin's sustainability initiatives. She also has experience as a project lead for the Royal Victoria Regional Health Centre during the COVID-19 pandemic. Rebecca has a keen interest in the role of new and existing healthcare facilities in Canada's commitment to reducing carbon emissions. Robin Snell is a healthcare architect with more than 25 years of experience. He has extensive experience with a wide range of healthcare projects across Canada, from master planning studies to the implementation of projects including private-public partnerships. He is an advocate for evidence-based design and is actively involved in the Parkin evidence-based design team and post-occupancy evaluation process. Robin is vice chair of the Canadian Standards Association Technical Committee for Healthcare Facilities, among other CSA committees, including a working group for low carbon climate resilient healthcare facility design. He is an EDAC and LEED accredited professional with recent healthcare projects in Ontario, British Columbia, Newfoundland, and Nova Scotia. Today, this duo will be presenting on the many paths to low carbon healthcare facilities. Now let's please give them a warm welcome.
So my name is Robin Snell with Parkin Architects. Very pleased to be with you today. We are going to speak about decarbonizing healthcare from a facilities perspective. And so essentially the bricks and mortar in the facilities in which you work and provide your care. Pretty straightforward agenda. We won't get into that too much. And so if you flip to slide number 3, please. You've already seen the statistic, 5.25% of emissions in the healthcare sector. I think I saw another statistic that said of 63 countries, Canada ranks 5th worst per capita on carbon-based emissions as a direct result of the healthcare sector. Next slide. In November 2021 at COP26, the Canadian government, in association with a lot of other national government agencies, World Health Organization, et cetera, made 3 commitments. Commitment number 1 was that we had a commitment to provide climate resilient health systems. We'll touch on that a little bit today, but really that's a parallel and separate topic. So as amidst all the forest fires we're having here this year in Canada, so resilience is an important element. Next slide. The next piece is a notion of committing to sustainable low carbon health systems. So not just facilities, of course, infrastructure and a lot of things that the previous speakers were just talking about. And so a commitment to sort of create a plan and a path forward. Next slide. Canada did not commit to be net zero by 2050. in the healthcare sector. Wondering if we ought to have or should, but there's still a striving for low carbon healthcare. Next slide. But an important piece to mention is on the building and the architectural side, there's a lot of focus on energy and the operational carbon, but not a lot of focus on the embodied carbon, essentially the carbon embedded in the materials we use and the process to get those building materials there and through the life cycle. So Rebecca is going to speak about that. So that's just a general introduction, and I'll turn it over to Rebecca. Thank you.
So why is it critical to focus on low carbon solutions? And I think we've heard many stories of the high carbon kind of nature of the healthcare system, but really these graphs show the urgency of the challenge. So we need to reduce carbon significantly, very quickly, to try and retain the global temperature increase below that 1.5 degrees C above pre-industrial temperatures. And the graph on the left shows really kind of our current policies aren't really going to get us there. And so there's a genuine global multi-disciplinary commitment required to really focus on low carbon solutions. And from a healthcare sector perspective, we've heard a lot today about what we'll call scope 3 emissions. So supply chain and healthcare delivery emissions. But what we're going to talk about in this discussion is really scope 1 and scope 2 emissions. So focusing on the carbon that goes into the actual healthcare infrastructure, and B, its energy use and how to reduce the carbon in those elements. And really, the keys to success in reducing carbon is really an overall collaboration between government, public, and private sectors. And so we're going to look at some samples today of that really key collaboration and how it's successful and really driving change. In the first instance, really the project, the common threads of these systems that we're going to look at from the NHS, Toronto and BC are really the development of new playbooks and the focus on the development of legislation and a framework to drive change. Number 2 is an investment in tools to drive that change and support procurement and changing procurement practices. And then 3 is really investing in low carbon pilot projects so that we can all learn from precedents and really drive innovation. So we're going to look at the NHS system first, and really the NHS in the UK has legislated a strategy to reduce the carbon footprint, and they really have an overall a commitment across their entire organization to reduce the carbon footprint at multiple levels. This is kind of running in parallel with a strategic investment in replacing and improving their healthcare infrastructure. So they're really focusing on changing, on investing in low carbon technologies for their infrastructure components and changing the way they deliver care and focusing on low carbon solutions. And you've heard some of those solutions already today. In Toronto, the Toronto Green Standard has been around since 2010, and really it's a market transformation tool. And again, its focus has been to legislate change for reducing the emissions of buildings across the city, really encouraging the understanding of the amount of carbon that goes into the construction of that infrastructure. And number 3, creating new partnerships and across city development strategies to really partner low emissions buildings with prioritizing green infrastructure, which includes reducing stormwater runoff and increasing the canopy and overall biodiversity in the city. And then as we look at BC, really the BC legislation really looks at improving the efficiency of buildings by 80% by 2030, encouraging retrofits through incentive programs, just a blanket kind of LEED Gold certification requirement, and that includes their healthcare infrastructure, and a really strong support for low carbon building innovation like their Wood First program. And that includes using wood construction in their healthcare projects as well. And so where do we start? There's a lot of legislation, but how do we start? And the first thing we look at is understanding the current state. And again, we go back to the NHS. They've been collecting data on how much energy is used in their healthcare infrastructure since 2008. And they've been able to really leverage this data to understand how they operate their healthcare system and where they can strategically invest to reduce the carbon footprint of their infrastructure. Number two is really looking at how do we use our existing infrastructure better? How do we build nothing, which sounds kind of odd coming from architects, but in the first instance, how do we build nothing? And in the second instance, if we're going to build something, how do we embed long-term flexibility so we can accommodate changing care models into the future? And really looking at new ways of delivering care. And we have seen a significant impact in reducing the carbon footprint of healthcare delivery through telehealth, and COVID was the catalyst of that kind of significant change. In the next, the next thing you look at is the material choices and how we build our projects, and looking at the embodied carbon. And this graph really shows that today, the embodied carbon is the initial kind of how much carbon goes into that project on day one. And as we reduce the energy consumption of our projects and as we clean up our grid, really that embodied carbon is a really important piece of the puzzle. There's multiple ways of reducing the embodied carbon, and it's really focused on how we procure materials and where they come from, and their capacity to be disassembled and recycled and have a circular economy, kind of a full cradle to cradle approach from a building perspective as well. And then really looking at the life cycle analysis and understanding the true carbon footprint of our materials. And from an LCA perspective, the structural components of our infrastructure have the biggest carbon footprint. And so how can we be really innovative of reducing the carbon of our structure? And really that's tied to the carbon in concrete for structures in Ontario. Number two, as we go to kind of a more micro scale, as we fit out our rooms in our hospitals, the NHS has developed a really interesting strategy to standardize a series of room types. It's not only standardizing size, is kind of similar to what we would do with CSA, but also looking at standardizing the finishes and what we put into those rooms, and really controlling the life cycle and the carbon footprint of all of those finishes on a micro level. Oops, sorry. And then finally, once we get to operating this building, really looking at the fuel and how the energy that goes into this building, and Robin's going to point out the kind of significance of switching the fuel source for our buildings. Back to you, Robin.
Thanks, Rebecca. So for fun, we're going to run through a few case studies of projects that we're currently working on. So start off with North York General Hospital. So maybe a couple of years ago, a year or two ago, we did their formerly named Stage 1, Stage 2 Master Plan Functional Program project with them. And I touched on resilience in the introduction. And so North York General is situated right in the midst of a floodplain. So obviously careful consideration of extreme worst case flood scenarios as climate conditions get more and more extreme. And so working extensively with the Conservation Authority to basically model and project the absolute worst case flood scenarios and then mitigation strategies. But the primary topic, if you flip to the next slide, is really about energy. And so the white part is their existing facility. They're proposing a significant new bed tower on the south side. And so really the biggest move to go to low carbon is geothermal heating and cooling. So a lot of analysis to see whether we can get geothermal fields both under site towards the river with blessing from the Conservation Authority, as well as under their existing building. So I think a key stat you might see there is the notion of an estimated 0.5% capital cost premium. So with that sort of lowish number, we can kind of sneak it in there with the Ministry of Health. I hope I can come back to that. The next one is provision for photovoltaic. So a lot of roof a lot of flat roofs, including parking structures and healthcare facilities, a lot of space for photovoltaics. But right now, the return on the investment just isn't proving worthwhile, but we make provision for it. So when it does, we're ready. Next slide, please. Similarly, at North York General Hospital, there were a couple of clinic spaces that were essentially moved out into the community. Rebecca, are we frozen? Or are you okay to go to the next slide? Okay, perfect. So I won't get into the clinics, outpatient clinics too much. Essentially, two different clinics, two different parts of the community, different purposes, moving care closer to home. So right, that in and of itself can reduce travel, et cetera. And we're able to go to sort of more efficient spaces rather than the acute care hospital setting. If you flip to the next slide, so one of the key elements for this is what's our energy source. And so in this case, which surprisingly was quite innovative at the time, about 3 or 4 years ago, is to use air source heat pumps as including a mini surgical center for the primary heating and cooling source. And that works well in Toronto, wouldn't work so well in the far extreme parts of northern Canada or even the northern parts of Ontario, but suitable here. Generally, it can provide heating until about -10 or 12 degrees Celsius. It breaks down in efficiency after that and goes to backup systems. Next slide, please. So, sorry, I have a pretty significant lag. Apologies for that. I think the next slide coming up, hopefully it's showing for you. There we go. Corner Brook Acute Care Hospital. So that's in Corner Brook, Newfoundland. I'm heading out there next week to see it. It's almost complete. Been a long time under construction. So this one we're quite proud of. To the best of our knowledge, it's going to be among the first, if not the first, zero-emission healthcare facility in Canada, possibly North America. You can see an interesting stat that it's the largest geothermal system in Canadian healthcare. So for those who don't know, natural gas is fairly scarce in that part of Newfoundland. They draw on hydroelectric power, and once the Muskrat Falls project is complete, government scandals notwithstanding, it'll be a very clean source. And so we'll have zero emissions with the exception of emergency power generation, which is required by code to be diesel fuel. So you can see some of the statistics there, some of the savings, some of the cost savings, some of the energy savings. And so we're very excited to have this entire acute care facility as zero emissions. So that's an important piece and an important direction in healthcare. So next slide, please. The last one I'm going to talk about is an interesting project in British Columbia. It's the Cowichan District Hospital. It's in North Cowichan. It isn't just interesting for sustainability initiatives. If I could go as a slight aside, it's a new procurement model called the Alliance Model. Extensive Indigenous engagement in this project, local art, et cetera. Raising the bar, in our opinion, on the patient care experience, while at the same time being one of the most environmentally sustainable building projects that we've been able to work on. And so it's fully electrified, which is very important. A lot of electrical rooms. Even the kitchen is electrified. And in this case, we're able to make the business case for photovoltaic work. Mass timber, getting to the embodied carbon element. So this is the next slide, and we're just about to wrap up. So this project has worked well for embodied carbon systems. It goes to a 20% reduction in the concrete systems in embodied carbon. And also an interesting notion of operable windows, which is less about energy savings and more really about the quality of the patient care experience. And like I said, in this case, photovoltaics business case, we were able to make work. So just as a quick wrap up, we've sort of come a long way in provision of sustainable low carbon healthcare environments. We really feel there's a paradigm shift. The industry in general is momentum is built, and it's in the mindset, and virtually every project we're involved in, it's not a battle anymore. A lot of initiatives and a lot of common practices. So these all electric heat pumps, geothermal energy practices are just commonplace. They're a done deal. and momentum is building on the embodied carbon, and mainly because all the code standards guidelines are changing and evolving. You heard Rebecca talk about some of the standards, but we're not there yet, a long way to go. From our perspective, we see a bit of a misalignment between technology, policy, economy, markets, et cetera. And a great example for that is photovoltaics just can't work from a business case standpoint in Ontario and many parts of the country yet. Hopefully something we can continue to work on. And here's an interesting one. We find a disconnect between capital funding approval, which is looking at today's costs, and return on investment and long-term investment initiatives where there's a longer-term payback, and that's something that needs a bit of work. Rebecca mentioned the cradle-to-grave concept. And that's really not that inherent in our process. The notion of this life cycle analysis and planning for existing infrastructure. And lastly, as I mentioned, the embodied carbon really needs to build momentum. It's lagging a little bit behind in our experience, but catching up. So hopefully that gave you a really good quick synopsis of where the sort of building industry is going, and what opportunities we have. So I think on that note, we're able to turn over for a question or two.
That's great. Thanks, guys. Great presentation. Greatly appreciated. We have a question here now for those that are tuning in outside of our South Georgian Bay region, Collingwood region. You may not know that we're also in the midst of a redevelopment process. And so we're going to, this question seems to bring that back a little bit closer home. And so after showing us the case studies and explaining what can we do more of, are there any initiatives that are going to be in place for the Collingwood General Marine Hospital setup? And that's the question.
So funny you should mention that. So I'm involved in the master plan there. It's been a great process. Essentially, we're finished the stage two work. I didn't include it because I didn't fully know the extent to which it's confidential at this stage or not confidential. So I'll maybe keep talking a little bit, and Michael can put me on mute or something like that if I'm saying things that I'm not to. Basically, all I'll say is that we were able to, in the proposed new development for Collingwood Marine master plan, we are using geothermal systems. We are looking at provision for photovoltaics, et cetera. It's too early at the stage to get deeply into the embodied carbon principles. There are opportunities for things like stormwater management, salvage water for irrigation, that sort of thing. So lots of different initiatives already in place. But that project's still awaiting funding, so I have to be a little bit careful, I think, about what we can say is approved and not approved. Don't know if Michael's on the line and allowed to chime in or not. I don't know.
I appreciate that. Thank you so much. I won't push you any further, just in case we cross any of those lines. So that's greatly appreciated. And thank you so much for taking the time to come and present and share your perspectives on this topic. Thanks again, guys.
Thank you for the opportunity.
Thank you very much. Bye now.
Great. So at this point, we had built in an intermission, but usually that's there to kind of help us buffer. So that's what we're going to do. We're just going to keep going forward. So appreciate you sticking online and looking at our next speaker. So with that in mind, I'd like to welcome our next speaker. It's Brenda Armstrong, the Program Manager of Environmental Health at the Simcoe Muskoka District Health Unit. Brenda is a public health professional with over 20 years of experience. She graduated from the University of Waterloo with a master's in public health. Brenda provides leadership in key public health activities to promote climate change, health, and healthy, equitable communities. Together with Sarah Warren, a public health promoter with climate change and health at Simcoe Muskoka District Health Unit, they have created this presentation on health in a changing climate that Brenda will now share with us. Please welcome them.
So thank you for having me here today. My name is Brenda Armstrong. I'm a program manager with the Simcoe Muskoka District Health Unit. And in my role there, I lead our work around climate change. So I'm speaking today about some of the work that we've done, doing some research to understand the impacts of health and our vulnerabilities in terms of the changing climate here in Simcoe Muskoka. Before I get started, I'd first like to recognize, like many of us on the conference today. I'm of settler descent on this land that I call home. I'd like to acknowledge that this land where we're joining from today is the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of the Chippewas of Beausoleil, Rama, and Georgian Island First Nations. I also acknowledge the Potawatomi of Moose Deer Point, the Mohawks of Wata, and the Georgian Bay, Moon River, and Barrie South Simcoe Métis councils in this region. The Huron-Wendat and Haudenosaunee Confederacy have also walked this territory over time. I encourage everyone on this call to make some time today to connect with the land that you're situated on in a way that's meaningful for you. You may want to explore nativeland.ca, start or continue your own learning journey, or physically or spiritually connect with nature. So in our presentation today, I'll review some of the evidence we've gathered around our changing climate, explore some of the climate health impacts, and we'll talk about some climate change action. It's interesting to be speaking here today on climate health when we've most recently experienced the poor air quality associated with the wildfires across Canada, certainly evidence of impacts of our changing climate. The work that we've done in terms of our climate change research has been around health vulnerability and assessing the impact of those climate impacts on our population. So we looked at exposure, sensitivity, and adaptive capacity when looking at climate health risks. And we gathered data to understand climate impacts on extreme temperature, air quality, vector-borne disease, extreme weather, food and water impacts, and ultraviolet radiation. When we talk about vulnerability, it's important that we think about health equity and the various ways that individuals can be vulnerable or conversely have resiliency to climate change. And so this really does impact vulnerability across a continuum, as demonstrated here on the slide. So we do look at climate drivers, how people are exposed, so those pathways, what the health impacts may be, and what we're looking at in terms of health outcomes. In terms of our climate change health assessment, I certainly can't take full credit for this. There were others in the agency that were leads in this work. So I just want to acknowledge that this was a number of different programs, departments, and external partners that we worked with to do our climate change vulnerability assessment. We looked at available external data, so looking at climate projections, literature reviews, local surveys, etc. We also had a wealth of internal surveillance information that we were already using to inform our programs. So for example, our vector-borne disease surveillance program, results from our comprehensive water testing programs, and evidence around foodborne illness. We also had stakeholder input from 22 focus groups and 15 key informant interviews. And we use this really to scope this work both spatially, so looking across the geographic extent of Simcoe-Muskoka, and temporally looking at the impacts from climate projections over time. So when we talk about climate change, we're really looking at long-term changes in the state of the climate, meaning the variability of weather conditions over time. So when we looked at temperature, we found that there would be, a general increase in annual mean temperatures and milder winters. And so these shifts are going to shift our climate to be potentially, in 2050, more like Kentucky, and by the 2080s, a climate that would feel more like Mississippi when we think about how we would experience that temperature change. We also expect extreme heat and extreme cold events, and more frequent, severe, and extended duration heat waves. And certainly we saw that in the BC heat dome, certainly predicted to happen here. Additionally, we anticipate more frequent extreme weather conditions. So with that, we're talking thunderstorms. Those can lead to forest fires from lightning strikes, increase in tornadoes, and increase in severe winter storms, and also projecting changing precipitation patterns. So we will see an increase in droughts because of changes in summer precipitation patterns and more extreme precipitation events that happen in shorter periods of time, which can result in flooding. So diving in a little bit to extreme temperature changes and health. So overall, we are already seeing a warming trend punctuated by extreme heat events, and we will continue to see more extreme, longer duration heat waves, and extreme cold will still occur, but we do really worry about the health impacts of extreme heat. Extreme heat can cause significant heat-related health impacts, and we can see from the graph on the slide here that we have a direct correlation between heat events and emergency department visits. Existing illnesses, including cardiovascular and individuals with respiratory diseases, are at most risk to heat events. Of particular concern as well is that when heat does not dissipate in the evening, we call those tropical nights, which we anticipate more of in climate change as well, does not give our population an opportunity for respite from the heat and can further exacerbate heat effects. And certainly that was part of what was seen during the BC heat dome. Extreme heat can also impact mental health and community well-being. It can worsen mental health issues and mood disorders, anxiety, depression, and it's also been linked to an increase in irritability and aggressive behaviors. So individuals who live in urban centers, work outdoors, live in low income situations are often more exposed to extreme temperatures. And the young, the very young, the elderly, and those with chronic illness are most sensitive to the impacts of heat. What we also project in terms of climate impacts is an increase in the frequency and intensity of these extreme rainfall events. So what this means is that our infrastructure planning, which plans for 100-year rainfall events, we are actually now seeing those rainfall events at closer to a 10-year frequency. And so with that, our infrastructure just does not have the capacity to respond to that intense volume of a rainfall event, and can lead to flooding. So, and that leads to primary health outcomes, injury and death related to floods, and secondary health outcomes in terms of food and waterborne illness, respiratory diseases related to indoor air quality associated with flood impacts, and mental health impacts from the stress and trauma of directly related to the event and impacts on personal homes. There's also damage to infrastructure and personal properties. Most recently, we've experienced this, but certainly air quality overall has been improving across Ontario since we've moved away from coal-fired generating stations. But climate change certainly has the potential to increase levels of air pollutants like ozone and fine particulate matter. And certainly, as we've seen most recently, wildfires can most certainly contribute to poor air quality from particulate matter and other gases as well. Climate change is also going to change the characteristics of our pollen season, so further exacerbating allergies and making management of allergies challenging, and will lead to exacerbation of existing respiratory conditions like asthma and COPD. So near and dear to public health's heart is looking at food and water safety and security. And so we definitely see that the rising temperatures and changes in precipitation patterns will impact quality and quantity of food and water, in part due to increased rates of contamination from bacteria and viruses that can make people ill. I'm sorry, I just got a message pop up while I was speaking. So certainly bacteria is more likely to colonize and grow on crops in warmer temperatures. Overland floods and increased nutrient loading in water can contribute to poor water quality and increase the risk of blue-green algae blooms. Overall, we, year after year, see a trend of increased food and waterborne illnesses in Simcoe Muskoka in the summer months, as can be seen in the graph provided on the screen. In addition, we also anticipate increased health impacts from increases in ultraviolet radiation exposure. Ultraviolet radiation interacts with factors of climate change, temperature, levels of ozone, and pollution to increase exposure to UV radiation. And our changes in behavior in terms of outdoor activity also leads to more exposure. This can lead to non-melanoma skin cancer rates increasing. And we estimate that basal cell will increase by nearly 8% by 2050, and squamous cell carcinomas increasing by almost 15% by the 1950s. In addition, we're already seeing changes in the number of vector-borne diseases and the types of vector-borne diseases that are common in our jurisdiction. So most recently, we've seen an influx in tick populations driven by our milder winters and the ability for ticks to better establish in our jurisdiction. And this has led to an increase year over year of Lyme disease cases in Simcoe Muskoka. Our active surveillance efforts have continued to identify Lyme disease risk areas in our jurisdiction, and that has increased year over year as we've done that work. So overall, we can also see that climate change and mental health and well-being are linked. There are a number of influencing factors that contribute to poor mental health outcomes, but we also see that climate anxiety is leading to depression and stress and straining existing social relationship. Grief is a complicated experience, and many individuals are already experiencing climate grief related to the changes that we're experiencing in our communities. There's a lot of really good research work happening currently looking at the impacts of extreme weather events, floods, wildfires, et cetera, all linked to climate change, and the abilities for communities to be resilient and the impacts on the well-being of those communities as well. So further information to come and evidence to inform our practice moving forward. certainly, I think it's important that we recognize this is, we have this once in a lifetime opportunity to make change. And I feel that the opportunity for action in the context of COVID-19 recovery is an unprecedented opportunity. We have opportunities that exist around mitigation and adaptation. Mitigation is action to stabilize, reduce, or cut off greenhouse gas emissions. So that's reducing our emissions or increasing carbon sinks, like trees, for example. And this is a goal to reduce the magnitude of climate change to a level that is manageable. We recognize that we're not able to reduce it to a level such that it is prevented. It's already happening. And then on the other side of the continuum is adaptation. And adaptation is actions that prepare us for and help us adjust to and cope with the impacts of climate change. So that's preventing or reducing impacts and capitalizing on benefits. So our goal here is to reduce exposure, reduce sensitivity, and increase our community's adaptive capacity or resiliency to climate change. And from a positive perspective, most climate actions actually have healthy co-benefits. So when we act on climate change, we also improve many aspects of our communities and improve overall determinants of health for our communities. So where to start in thinking about how we come together and improve our community's resilience to climate change. So we all have the opportunity to make a difference. We can expand our knowledge. We can communicate our understanding of the climate health risks of climate change and the benefits of individual action to reduce greenhouse gas emissions. We can advocate for local climate action and provincial climate action strategies that reduce exposure and expand adaptive capacity and resilience. And we can lead by example by each taking steps to reduce our own carbon footprint. So in summary, our climate's changing. Locally here in Simcoe Muskoka, we're already feeling these climate impacts. We've discussed that these climate impacts include rising temperatures, increased extreme weather, and precipitation events, but that climate action has so many health benefits and will build our resilience and create healthier, stronger communities moving forward. We have the knowledge and we have the technology that we need to act. So with that, I thank you. There's a following slide of additional resources, and I'll stop sharing my screen to take questions.
Okay, it's Brent. Great, Brenda. Thank you so much. That was great. We do have a question here for you. And within your presentation, you spoke about vulnerability and health equity across various social determinants of health. Can you expand on your example of how those that have stronger risk factors are more likely to be negatively impacted by climate change as a whole?
So really what we look at is for individuals who have vulnerabilities. For example, individuals who already have pre-existing health conditions, individuals who are living in low income, have less resources to have capacity to deal with events. So if I put that in perspective, when we think about the current situation of the wildfire smoke impacting air quality in Simcoe Muskoka, those individuals who are most at risk would be individuals who have pre-existing cardiovascular or respiratory health issues. And the best way to address challenges associated with wildfire smoke is to actually remove yourself from breathing in wildfire smoke. And so that means having access to indoor space with clean, cool air. So those individuals who are living in a lower socioeconomic situation may not have air conditioning, may not have access to higher quality air filters in their HVAC system, and may not be able to get that respite from the smoky air conditions. Well, hopefully that answers your question.
That's a great example.
Thank you so much. And quite timely of what's going on in Ontario.
Okay, thanks for your talk. We're going to move on to our next speaker. And so thank you again, Brenda. So up next is Dr. Miles Sargent, family physician who has worked with vulnerable populations, including new immigrants and refugees, people experiencing homelessness and or addictions and the elderly over the past 25 years. He graduated from the Michael G. DeGroote School of Medicine at McMaster University in 1993, and then completed his family medicine residency at Queen's University in 1995. Recognizing the intersection between environmental issues and health, he's dedicated to addressing climate change issues and has co-founded partnerships for environmental action by clinicians and communities for healthcare facilities, the Charity Trees for Hamilton in 2012, and the not-for-profit Shelter Health Network in 2005. He's now the Executive Director at the Canadian Coalition for Green Healthcare, and we are honored to have him here today to present on how to make your hospital environmentally sustainable. Welcome, Miles.
Thank you very much, and great to be here, and I appreciate the invitation. And also want to say thanks to Brenda for covering all the tough stuff, and I get to kind of do more of a good cop thing. She's done the bad cop piece, which is always tough. You never get invited to a dinner party when you do that part. So Peach Health Ontario started about 2 years ago. And we started by imagining what an ideal green facility might look like. And we worked with a young architect and discussed with him what elements might be in an ideal green facility. And this is what we came up with. And I'll go through the different sections here. I think I have 20 minutes. So I'll keep an eye on the clock and go fairly quickly. So Peach, as you correctly said, is partnerships for environmental action for clinicians and communities for health facilities. Easier just to say Peach. I think we've discussed all this stuff already, so I kind of get to skip past this one. And I know sometimes your first speaker uses this slide as well. I added a bit of a Canadian element to it in the columns, basically just showing that these things do happen in Canada as well. And certainly at 12 o'clock, 1 o'clock there, we're seeing, smoke like we haven't seen before. You could go through all these things, but I think other people have done that. So I'll just move along. And I'm not sure if you saw this one. I'll just quickly say that this is the global greenhouse gas emissions over the years, starting in the left corner, 1990, moving up over 30 years, the black line to now 50 gigatons. Then we paused a bit during COVID. And we need to follow the red line, the bold red line, in the next 7 years to have a 50% reduction in global CO2 in order to follow that 1.5 degree pathway. And there is a way I think we can do this, and we will see. So yes, Canada does have a lot of emissions per capita. This is a few years old. We've actually gotten a little bit better, which is nice. And Canada has 5% of their national carbon footprint is healthcare. This is the same as all the wealthy nations. North American, European, Asian, the wealthy nations, they're typically around 5% of the carbon footprint. So it is a significant issue for us in our sector to work on. Because of that bold red line that says that we need to decrease by 50% in the next 7 years, we do need a culture of sustainability in our organizations, just like we have cultures of safety or EDI. But we felt there needed to be a different approach to get there faster. And so our approach was to reach out to all the climate stars in the province, and there are a lot of them. And we learned about them a couple of years ago, and we contacted them, and we had them tell their stories on the Peach website. And then we thought of ways that we can mobilize this knowledge that they had to other facilities. And so one of the things we do is like what I'm doing today, talking to hospital employees about how to make your hospital more sustainable. One of the key things, of course, is to go after the big items. So we've categorized these various parts of a hospital this way: leadership, education, supply chain, etc. And I'll go through each one. And within each one, we've tried to find a significant project which will move the needle in terms of carbon production. Leadership, obviously incredibly important. Clearly, your hospital has leadership that is thinking about a strategy, or we wouldn't be doing this today. And I give examples of a few hospital systems in Ontario that do have a strategy around sustainability. There are many now, which is great. And there are more and more as every 6 months goes by. This is becoming, I mean, popular is the wrong word, but we are seeing more and more of this, and people are concerned now. UHN has developed a culture of sustainability in Toronto because they've been doing this for 20 years. CHEO has carbon targets that they've set. They try to decrease by 5% per year. I think this is their 4th year now. And Sunnybrook set up a task force across their hospital with varied leadership. You also need a person responsible. One of the things we do at Peach and at the Coalition, this was done in partnership, is develop learning resources for leadership and for employees. And this is the guide for hospital leadership for hospitals. And this is on both the websites of the Coalition and for Peach. This is the centerpiece of it. These are the items we feel you really need to go after. It's essentially a Pareto analysis, the 80-20 rule. I would suggest there might be 300 items you could go after at your hospital in terms of taking on initiatives to decrease carbon footprint. We thought a lot about this. We had a fairly big group of people around the table, the virtual table, thinking this through and what the biggest ones are. And these are the 22 we felt were maybe the most important in terms of decreasing your footprint. And there's a few things in here that you wouldn't normally see or expect. And one of them, for example, a lot of hospitals do have foundations and have a fair number of funds in those foundations. And are you divesting those funds from fossil fuels to low carbon funds? The other point I like to make on this slide is that I think that when we think about greening a hospital or any structure, we think about the facilities person or the engineer working in the basement. And that is important. That's under buildings and energy, and there's 5 items there. But there are a lot of other areas, and that's why the Sunnybrook model is the same thing we're doing at Helm Health Sciences. We have the food manager. We have someone who can talk about transportation, supply chain, or procurement, all at the table. Choosing wisely is extremely important. It's important for various reasons, for the original intent of choosing wisely. But of course, when you are choosing wisely, you are ordering less tests. Every test has a carbon footprint. And that's why this is important for sustainability. And choosing wisely realizes that. We've done a couple of projects with them. One of our publications you may have seen last September or so in Healthcare Quarterly is our low-hanging peach tree. And the full article shows a tree with 3 different colored fruits on it. There are the green ones, which were the ones which had under 50 tons of CO2 per year for a 200-bed hospital. And then the yellow ones, which were between 50 and 100, and then the orange ones, which do have over 100 tons of CO2 per year for a 200-bed hospital. So those are the ones that you want to go after. Those are the ones I've highlighted right here. And you do see the building-based ones are tend to be the more expensive ones. This does have a cost scale on the side, which is logarithmic, so it goes up very quickly. Basically, there is a zero or neutral cost in the middle of the tree. And then the things above it, as you can see, going up quite quickly to building a whole new building, of course, hundreds of millions of dollars. And then at the bottom of the tree on the ground are the things that actually save you money. So deprescribing medications by 5% at a 200-bed hospital does save you between $200,000 to $300,000. And that's why deprescribing is on the ground there. And it is also a game changer in terms of emissions. So you can see the things in the neutral area there, green procurement, I'll talk about in a second. I mentioned decarbonizing investments, moving to plant-rich diets. Our next speaker might be speaking more about that. I had that at cost neutral. She just sent me an article the other day saying this actually does save money. So a couple of years ago, I saw this for the first time. It kind of blew my mind. The carbon footprint assessment of the health system in England. And so this is that 5% of healthcare within the entire footprint of the country. What does that pie look like? And again, this would be ambulances and primary care and hospitals, everything all mixed in together. At 11 o'clock in green, you see travel, personal travel, which is patients, staff, and visitors. Only 10% of the pie. We talk about travel a lot. It's still important. Everything is important on here to get to zero, obviously. But surprising, it's only 10%. And then the red piece is actually what's going on inside your buildings, whether it's a hospital or a clinic. Building energy at 8 o'clock, only 10%. This piece of the pie has decreased over the years in terms of the size because of all the new technology, LED lights, new boilers that are more efficient, et cetera. So what's the big piece of the pie? It is the supply chain. It is all the things that we buy or consume. And this in this model was 62%. There have been other places that have done similar studies, and it seems like every time a new study comes out, this blue piece gets bigger and bigger. Aga Khan University does some really good stuff here. They're estimating it at 70 to 75. A study done in Laval finished in the last 6 months, suggesting it is as much as 90 in Laval. So shockingly big. As you can see, pharmaceuticals, 22% of this pie. So the production of pharmaceuticals, 22% of healthcare's carbon footprint. Medical devices at 3 o'clock there on the right. So that's why the supply chain piece is so important. And what do we do about that? We think about the not the 3 R's, but the 4 R's. The first one being refuse the bad products. I encourage you, if you don't know about the circular economy, to look it up. We have been using the linear economy for a long, long time, all around the world. And that, to give an example of a gown, the throwaway gown does need to be dug out of the ground. And then it is shipped to manufacturing, shipped to packaging, shipped to the hospital. Then someone like me uses it for 60 seconds, throws it out, shipped to garbage. So that is the linear economy, from digging it out of the ground to the death of the gown. A washable gown, of course, is part of the circular economy, because yes, it does need to be dug out of the ground. It needs to be produced, but then it starts circling into our system. We're using it at least 200 times, and it might have a life after it's done as a gown. And that's what we need to be doing with all our products. And as a little aside, as we sort of seeing and smelling the smoke in the last few days, if you're wondering personally what you can do, there are obviously some good websites, and I'm sure a lot of you know, in terms of transportation, in terms of avoiding meat products and shifting over to plant-based things. Again, I'll leave that for Amy to talk about. But maybe the biggest thing is what we buy, because as clinicians, maybe particularly the physicians in the group, we make decent money. And so we spend the money. And it's really what we buy personally, which is the biggest issue. And you can see that on that supply chain piece. So can you buy used? And sometimes it's frustrating. We have a fridge. I'm sure most of you have fridges, and our plastic shelves break. And you have to pay $300 to replace a little shelf. And I remember a few years ago, I'm based in Hamilton, trying to find a place I could buy a used shelf. Like, is that so hard to ask? And I found there's a place in Thunder Bay that sold these things. And unfortunately, they just gone out of business, so I missed out. But when people think about the economy and the fact that we're not buying things, we need to buy things used. And we need to figure this out in our sector with healthcare. So what we've done is we have started a procurement working group in Ontario, provincial group. And Dr. Orling is part of that group. So we have anesthetists and surgeons, but primarily we have the procurement leads of some of the big hospitals in Ontario. And we are looking at adding sustainability weighting to the RFPs for everything that we buy, whether it's masks or MRI machines. And so instead of just thinking about cost and quality of a product, we also need to think about the sustainability of the product, and that has to be part of the weighting. And we are making progress on this. This shows the supply chain of a computer, and this was really done around COVID issues and the problems with supply chain, just demonstrating where things travel, but it also demonstrates why things have such a big footprint. The computer starting as a raw material in Chile in this map, number one, moving over to Southeast Asia, number two, then moving further north into Asia, three, then into China, number four, final assembly, then back across to Mexico for packaging installation, then up to the consumer in Canada. There has to be another way of doing things. Sticking on the computer theme, there are ways that both in healthcare and as personal buyers, we can look at the rating of companies. And there's a number of places that do this. CDP.net is one of the oldest ones. It's a not-for-profit, which rates companies on their carbon footprint. And this rates a bunch of computer companies. Here you can see the ratings. 6 months ago, the federal government in the US, which is the biggest buyer in the world, announced that for all major contracts, companies they're buying from have to disclose their carbon footprint either through CDP or what I would consider an even better one, SBTI, if you want to check that out, science-based targets. So these things exist. We need to use them. This is also called value-based procurement. It's happening in universities, municipalities, corporations, health systems in other countries. We are one of the last at the table, but we are doing this now too. Extremely important. Drugs and devices, just quickly, a lot of people have heard now about meter dose inhalers, that 1 MDI releases the equivalent of 290-kilometer car ride in emissions. So we're suggesting to switch over to DPIs, which are not as harmful. There's some anesthetic gases. Good chance Dr. Orling spoke about this. Desflurane as much as 2,200 times worse than CO2. There are other options. I think there might be as many as 8 hospitals now in Ontario that have banned it. And deprescribing, you saw that massive chunk of the pie being meds. We really need to think about whether we're overprescribing or not. There are some things that we can do with building and energy, although we have been working on this for years and years, and one of them is operating room ventilation setbacks at night. Do all the operating rooms need to be cycling at 20 cycles of air for contamination reasons all night, or can you drop back most of your OR rooms to, say, 6 or 8 cycles an hour? I'm going to pass on this one. I guess the one thing I will say in terms of food is that if you look at Project Drawdown, it's another interesting thing to Google, Project Drawdown, you will see that the two biggest global solutions, I'm not talking about healthcare here, and I'm not just talking about Canada, the global solutions are both within the food category, one being plant-rich menus and the other being to decrease food waste. And here is the carbon footprint of beef at the top. And then you slowly move down in terms of carbon footprint to the vegetables at the bottom. Transportation used to be bike-friendly facility was the best thing we could do, and it's still a great thing to aim for, but virtual medicine, arguably even better, because then the patient doesn't have to travel because the patient's probably not riding their bike. And another thing we can do is advocate for the virtual conference like this today. This is a conference in England. It was a pharmaceutical conference, and someone did a study on the carbon footprint for the North Americans who stayed at home on the right and just used their office, which was about 10 kilograms of CO2 versus those who went to the conference, which you can see the airplane, big pink circle there, total of about 1,900 kilograms of CO2. So we need to have the virtual option. And finally, biodiversity. We are going to lose trees every year. We need to work hard to keep our trees and to have biodiversity and plant native species. We partner with a bunch of the big organizations in Ontario. I guess this is 2 years ago now, to create something called Trees for Health. And we have a goal of planting over 800,000 trees over the next 10 years in Ontario at or near health facilities. This is Hamilton General in 1910. I like to show that one because back then there were lots of trees around hospitals. I'm just going to go through the last couple quite quickly here, but the bottom line, this one is just showing why I talk so much about hospitals versus other things. This is an Australian study looking at the impact of various things like general practice at 4%, clinics 4%, specialists offices 6%, public hospitals 44%. I'm going to skip past the clinic stuff here. Climate action, who's responsible? I really do think there's a lot of finger pointing that goes on here. And sometimes we don't want to take responsibility. I do think we all need to step up and be climate action champions. There are 1,000 large facilities in Ontario between hospitals and long-term care. And so even if you only had one, that's 1,000 at all the different facilities, but we need much more than that to really turn this ship around. I do consider this a hobby, so feel free to reach me. There's a few different ways to reach me there. And finally, I did become the ED of the Canadian Coalition a few months ago, and our vision at the Coalition is not simply the ideal green facility, but the ideal green community. And this will be our webpage in a month or so, based on an aerial photo of Oslo, Norway, one of the most sustainable cities in the world. How does healthcare interact with the rest of the community? Healthcare is a massive part of a community. Hamilton Health Sciences has 15,000 employees, and then there's all the clinics in town. So a lot of people are, either in healthcare or married to someone in healthcare. And then healthcare itself, of course, interacts with universities, with innovators, with big manufacturing, with agriculture. So we have a massive impact on the community. The other thing is the fact that we are an anchor institution, a key institution in our community. And as a health institution, we should be shining a light, showing others how to do this. And the final thing is the fact that clinicians are a trusted voice, whether you're a nurse or a pharmacist or a doctor, physiotherapist, the list goes on. We are a trusted voice in the community, and we can spread this message, and hopefully people will listen.
That's great. Thanks, Miles. Great talk, and really appreciate you coming to do that. We just looking at some of the questions that were submitted here. One of them was another option to reduce the carbon emissions of transportation to healthcare facilities is through promoting the use of public transport systems. What are your thoughts on initiatives to make public transport services more green and just in other transportation processes in general, perhaps?
Yes, so there are lots of transportation options. I mean, there's also carpooling. Some would argue that buying a used gas vehicle is better than buying a new electric vehicle, getting back to the recycling idea. We at the coalition are doing a project right now on electric vehicle transportation to facilities, but what they call micro mobility as opposed to cars. And there's a lot of work in Hamilton on that. In terms of buses, yes, you can now get buses that are not gas-based, and clearly that is a great option. If you're in a big city, I believe a couple of the big hospitals in Toronto have shuttle buses that you can use, so there are lots of options out there.
That's great.
That's great. I know just touching on one facet of that expansive talk that you had, so greatly appreciate that. Okay, we're going to move on to our next speaker. So once again, thank you.
Okay, thank you. Have fun, Amy.
We have Amy as a climate program manager at Nourish Leadership, a national not-for-profit leveraging the power of food to improve the health of people, communities, and the planet. Amy spent over 9 years leading large hospital food and nutrition teams through major changes and improvements. In 2021, she was instrumental in launching Parkwood Institute's on-site gardening program for patient meals, in addition to composting, in-house production, and local procurement. She is a dedicated volunteer with a passion for local food security and basic needs provision. She graduated with an honors Bachelor of Science in Food and Nutrition from Western University in 2009 and completed her MBA with a healthcare concentration in 2021. Today, she will be presenting on reducing the climate impact of hospital food through planetary health menus. Thanks, Amy, and the floor is yours.
Thank you so much for having me today. As mentioned, my name is Amy Ford. I'm the Climate Program Manager for Nourish Leadership. And today I'd like to start a conversation about planetary health menus. So in our quick 15 minutes together, I'd love to cover the work of Nourish Leadership, the concept of incorporating planetary health into hospital menus, and talk about what the current issues are, what the potential might be, and how we at Nourish are involved. And then I'd love to introduce you to an incredibly helpful tool known as Cool Food. And I'll also touch on some work that's being done around new builds and retrofits and how sustainable food can actually be incorporated into that process. And then I think we will finish with time for maybe a question or two. So in our short time together, I do want to spend just 20 minutes on sharing a video. It really sums up the mission of what we do. And I'm doing the scariest thing a person can do, which is share a video live on a call. So here's hoping it works.
Take a close look. What do you see? A hospital tray? A platter for meatloaf and jello? The butt of a joke?
I was like, the only thing worse than airplane food is hospital food.
Well, I see a platform. I see a way to nourish. A chance to provide comfort 3 times per day. And a place to honor culture. Do you see a budget line of $7.43 a day? I see 500 million meals and a $4 billion opportunity to reduce food waste, to move the market toward better production, to fight climate change. Do you still see a hospital tray? We see a platform for the future of food and healthcare.
Wonderful. I trust that somebody would have unmuted and let me know if that wasn't going through. It's true. Nourish started with this simple idea. How could the hospital tray be a platform to dream big and transform the food and health systems? So we at Nourish, we're a charitable nonprofit that's working across Turtle Island, spread across Canada from coast to coast to coast. We love to work with individuals, organizations, whole communities within healthcare, academia, Indigenous communities, and the food system, all with the purpose of supporting them to leverage the power of food to build better health for people and the planet. So I come from a healthcare background, as was mentioned. For about a decade, I led the food nutrition services team at St. Joseph's Healthcare here in London. And I intimately know that Canadian hospitals are experiencing so many different pressures. We're all recovering from the global pandemic. There's the rising cost of everything, food being the worst. There's the climate crisis, and we're seeing signs of it right outside our doors. And then there's supply chain uncertainty. There's issues with recruitment and retaining staff. And this is all balanced with things like desiring to decrease hospital stay length and readmission. We want to contribute to patient satisfaction, of course. We'd love to move forward on the Sustainable Development Goals. Oh, and the Truth and Reconciliation Commission call to action. There's a lot to balance. So at Nourish, we would love to make an impact in 3 areas. When we talk about equity, that's the social justice or the EDI in food, and definitely about reconciliation. Community well-being looks like preventative health, food security for all, and using food prescribing that can value food as medicine. And then climate, which I really like to say is just treating the planet like it's an important stakeholder in our decisions. We recognize that a lot of these pain points are very interconnected, and we hope that we can support the healthcare food system to leverage that power of food to find better ways of doing things. We always talk about a future where food is actually part of the solution to all these pressures that we're currently facing. So we work in 4 main ways. Communications is highlighting the work that's being done nationally. So I think of the amazing plant-forward menus that are being created in BC, the Indigenous food offerings in Northern Ontario, the patient gardens right here in London, and yes, I was helpful to start those. But really capturing and sharing these case studies so we can codify the practice and let it spread to others who are interested in testing innovations. We love to start conversations that might lead to policy advancements. So things like supporting Canadian hospitals in their desire to serve hunted and wild foods, which now has a lot of barriers around it. And ensuring that Canadians have access to healthy and appropriate foods using social prescribing. We have an anchor cohort program that's a 2-year commitment to goal set, prototype, catalyze big dreams while working in a national community of practice. And that's how I got involved with Nourish when St. Joseph's London was chosen to be part of the anchor cohort. We have 2 action learning programs. The first is called Food is Our Medicine, and it's a self-paced learning journey or an online course that's all about traditional and Indigenous foodways, the impact of European first contact and colonization on those communities and on those foodways, and then exploring how food is culture and what could the path forward be when we talk about decolonizing our practice and contributing to reconciliation through food. And the second program is called Planetary Health Menus. So next week, we're so excited to publicly launch our Planetary Health Menus program. We're eager to share a number of resources around this, including things like the Sustainable Menu Guide that supports a food services team create a menu that actually puts sustainability at the center, and the Values-Based Procurement Primer, which is an entry-level 101 document to bringing other things into purchasing decisions outside of just cost and delivery expectations. All of this is going to support healthcare food service teams to buy and serve food that's really good for people and really good for the planet. And it also includes something called Cool Food, which I'm just about to discuss. So this program is in response to the growing threat of climate chaos. The Lancet report put it pretty bluntly. It's the biggest global threat of the 21st century, and tackling it would be our greatest opportunity. We know that the food and health systems have massive impacts to the climate. When we think of the food system, so growing it, harvesting it, processing it, the delivery, the eating, and then the discarding of the waste, that contributes to 1/3 of all greenhouse gas emissions globally. It's huge. Healthcare as well. 5% of emissions are coming from the healthcare system, or to put it another way, if healthcare was a country, it would be the 5th largest emitter. So like our short video at the beginning said, hospital food really can be the butt of a joke. At its very worst, it's some mystery meats and some neon jello surrounded by lots of plastic that's headed to landfill. It's delivered in quantities you don't really want. At times, you're not really hungry. Maybe it's not appropriate to the culture you come from. And it's often seen as adjacent to the true healing or medical journey, not centered in conversation, not part of future plans. Sometimes it's served on disposables that go to landfill, much of the food included. It can come from very far away, so it's associated with a lot of travel emissions. And then it arrives already made, probably frozen, ready to be rethermed. All in all, pretty carbon intense. But we do have a vision for how hospital food could be. It would be sourced sustainably from local farmers who have strong values about antibiotic use, regenerative practices, how to treat people, how to treat animals. The menu would change with the seasons. It would reflect the region it comes from. It would be plant forward, but still culturally mindful. So we talk about less meat, better meat. It would be associated with less food waste because it would be enjoyed by the person being served, and it would have less plastic going to landfill. All in all, it would still taste great and it would meet the patient's needs. So cool food is one way that we could get there. It begins with a commitment to a goal to decrease your organization's greenhouse gas emissions. In particular, we talk about a goal of a 25% reduction by the year 2030, because that's in line with the Paris Climate Agreement. Next, you're outfitted with a calculator. So this actually turns your food purchasing records into a personalized climate impact report. It will highlight which foods are the worst offenders and where there are some opportunities to make important changes to your purchases and your menu. The calculator can be used for reports year over year, so you can watch as projects and innovations actually move the meter and make a difference. And then there are resources to support the changes. There's a wonderful playbook about climate-friendly foods, and there are webinars that all of their partners join, even some big names like Virginia Mason and the hospital in the States, and IKEA, a place I like to shop and eat their food. We're so honored to have partnered with the World Resources Institute to bring cool food to Canadian hospitals so they can finally quantify the climate impact of their food and use it as a baseline to start making some really important shifts. Lastly, I want to draw your attention to some work that's being done on the West Coast. It's supported by Nourish as well as Cascades, and it's going to be a playbook that will outline the various elements that teams should consider when they're planning a new build or a significant retrofit related to infrastructure. So often when we work with hospitals, they want to do these really big, exciting, lofty projects and goals, but they cite that infrastructure is the issue. They're working with a hospital that was designed maybe in the 70s, and it just doesn't have the space or capacity for what they want to do. For example, we wish we could do on-demand room service, but we just don't have the space for it. Or we'd love to have a patient garden, but the only available land is so far from any water source. If this work is interesting to you, I've listed the contact information for Annie, who is leading it, and she's always very willing to chat with folks who might contribute to or benefit from the playbook that's coming out. There really are many considerations. So infrastructure can actually impact food waste strategies. Like if folks are supposed to eat all of their food that they were served, it should probably be in the right quantity. So you'd want to have them actually order the right amount of food, which would require on-demand room service, and that changes your space allocations. Or the ability to wash reusable serveware. So if you don't have the right dishwashing capacity, you're pretty much set to go to plastic. The ability to cook from scratch, you're going to need lots of different prep spaces, ovens, things like that. Or even receiving fresh local produce from farmers right out of the ground. Often teams will need to receive their things already cleaned, parboiled, processed, because they don't have the space to be doing that work in their kitchen. Currently, hospitals who serve hunted and wild meats, and there's only one in Canada, require a separate kitchen to have to store the animals. So if that's work that a group wants to do, they have to plan for it ahead. Before we go to any questions, I just want to tell you what's next for us. So as I mentioned, we're going to publicly launch the Planetary Health Menus program next week on Thursday. And I would love if anyone on the call could join us. It's going to be at 12 p.m. Eastern, and the registration is on our website at nourishleadership.ca. We also hold monthly sharing circles for anyone who's enrolled in Food is Our Medicine, the learning journey about Indigenous foodways. It's a space where people can talk about anything that's on their heart in a very unstructured environment, and it leads to some pretty incredible shifts in thinking. We are currently selecting our third 2-year anchor cohort, and we know the hospitals involved are going to be an amazing community of practice that will do great things. And then lastly, much to the opposition of what Dr. Miles just suggested about virtual conferences, we are going to hold an in-person symposium this fall in Saskatoon I hear Saskatoon is beautiful in the fall. We're going to be right at the mouth of the river in the beautiful Ramai Modern, which is a museum. And we're going to gather thought leaders, subject matter experts, people who are excited about food and health, and really get our hands dirty at learning some new things and committing to an amazing new future. So with that, I want to thank you for having me today. I want to say that this is my email that you can reach me at if you would like to talk about all of these things. And I will stay in touch on the YouTube if I see some comments that are related to food. But now I will pass it over if there is a question.
That's great. Thank you, Amy. That's great talk. Greatly appreciate it. Looks like just going to some questions. We have one here that says, you mentioned that 3.5 billion meals a year have already been impacted by this initiative. The question is, what has been the feedback from patients and healthcare teams?
Yeah, so there's been a lot of tracking being done to ensure that patients are enjoying and accepting the new plant-forward menus. And largely, they have extreme success with the way that they enjoy the food. You've probably heard about New York City going almost exclusively plant-forward in their hospitals, and they've been tracking their patient scores really intensely, and they've seen really high success. There's also a lot of work being done around the naming of foods. You think about if you see a dish on the menu that says vegan health bowl, it almost sounds like immediately you're not going to enjoy it. But if it's called seasonal avocado and black sesame power bowl, somehow you immediately, your mouth is watering. I kind of know the flavors that are going to be here. And it doesn't sound like the food is being restricted. Instead, it's featuring what's actually there. And so there's different tips and tricks to make sure that folks are excited to order the food, and then when they order it, that they're happy with it. And I think there might have been a second part to the question, if you want to remind me.
No, but we do have another question.
So that's great. This other question is, how difficult is it for a hospital to make a change to be plant-based? This one's from the chat.
It depends on the hospital and about how many people are internally championing the project. So we've had a number of hospitals through Canada move toward different levels of plant-based diets. And it can be as simple as Meatless Monday or For the Planet Friday, things like that, something fun. You also don't have to actually present a vegan entree for it to be plant-forward. So if you were looking at a from-scratch beef burger, and you could scale back to about 50% beef and be adding things like black beans or lentils, carrots, brown rice, those are ways where you can make mixed foods that are decreasing some climate-intensive ingredients, but still presenting something that's known to people.
That's great. Thank you so much. I think there may be some other questions in the chat, but at this point, we'll kind of move forward. And thank you so much for your time. Great talk.
Thank you.
Okay, folks. As Miles said in his presentation, there's pros and there's
the virtual world, and today, especially at the beginning of our day, you can see some of the side effects of the virtual world. We can see there's always little glitches here and there, but once we got through that, I think that we got to experience great, insightful conversations and presentations. So with that, I'm going to just say thank you all for joining us today for the 7th Annual Georgian Bay Healthcare Wellness Research and Innovation Day. Again, such an insightful day discussing the future of green healthcare. And we hope that you've enjoyed watching our live stream format and the variety of our fantastic speakers. Once again, I'd like to thank our incredible speakers joining us from around the country and province, and thank you for sharing your expertise and unique perspectives on such relevant areas of interest involving new sustainable medical technologies and environmentally conscious healthcare. Thank you again to our partner organizations who have brought you another Georgian Bay Healthcare Wellness Research and Innovation Day. And thank you to our team here at Colin General Marine Hospital and the Rural Ontario Medical Program who have helped to display the innovation and research initiatives alongside our Cinematrix media with their live stream technology. So thank you all. This day would not be possible without the many hardworking people who have worked behind the scenes in supporting and organizing another day. Would be great to have them pop up on the screen, but I'm not sure if that's possible. But nonetheless, we do have our sessions that are recorded So if you, your colleagues, your neighbors want to watch some of these a little bit later today, then they're going to be posted on the Rural Ontario Medical Program website. So www.romponline.com. It'll be showing up at the bottom of the screen. If it's not sure if it's if we're able to do that, but that's something that we can hope you can tune in and check out some of the recorded versions of all of this. Great. And with that being said, thank you all and see you next year.